The next talk is on Toric IOLs tips and tricks. I invite Dr. Nitin to please deliver the talk.
Dr. Nitin Balakrishnan is a very popular and uh, cataract and refractive surgeon. He has a very busy practice in Mumbai. Thank you, Dr. Nitin.
Thank you, Ritu, and for having me for this lovely IC. Toric IOLs are something which we all look forward to. In fact, the inclusion criteria for toric IOLs is now increasing with the increasing amount of accuracy, which we get from these IOLs because of perfect planning. Many of the slides and points which I'm going to make in this particular talk may be a repetition of what Dr. Bhalla and Dr. Parul have already elucidated. So what are the critical factors for success with toric IOLs? A good patient selection, preoperative measurements, that is keratometry and biometry, IOL calculation and knowing one's SIA, and certain intraoperative factors which we will show. Now, in a patient selection, when we're doing a patient with the rule astigmatism, any patient with an astigmatism of more than one diopter, and against the rule astigmatism, any patient with an astigmatism of more than 0.6 diopters would be a good candidate for a toric IOL. Now, it's important, however, therefore, to confirm the amplitude of the cylinder, and the slides are getting cut. Slides थोड़े cut हो रहे हैं. Slides नीचे से cut हो रहे हैं. It is important to confirm the amplitude of the cylinder, and it's important that we use at least two methods to see that there is a sync between the two methods as far as the amplitude and the axis goes. Also, in cases where a refraction is possible before, see to it whether the cylinder on refraction is similar to the ones which are measured by the various instruments. Studying the holiday EKR map is a very, very important thing. If it's available, it should be done. Now, in an EKR map, the difference in the mean EKR 65 readings between a 2 to 4.5 millimeter zone of the pupillary size should be less than 1.2. The difference in the axis in this zone should be less than 10 degrees. And the histogram, that is the histogram as seen over here, should have either a single or a double peak and should not be a very skewed histogram. So this shows that this patient has a regularly irregular cornea, and therefore he's a good candidate for a toric IOL. On the other hand, if you see this EKR 65 map, you see the amount of difference in the mean EKR 65 reading between 2 to 4.5 millimeters. That's more than 1.2. The difference in the axis is more than 10 degrees. And if you see the skewing over here, it is skewed over a very, very wide zone. And therefore, this histogram map clearly shows that this patient is therefore not a good candidate for a toric IOL. And one shouldn't take him up for a toric IOL as far as possible. Now, there are various errors in measurements. Dr. Parul has already shown this. If the head is not sticking to the head bar before while doing the measurements, if the head is sticking to the head bar but there is a tilt, and at the same time, in case of a normally positioned patient, see the amount of difference. The difference can be as much as 1 diopter in magnitude and almost 10 diopters in axis. And therefore, it's very important, like Dr. Parul mentioned, that your assistant or your optometrist be told how to take these readings and probably repeat the readings in case the differences are being seen. Coming to the toric IOL power calculation in the preoperative planning, we can either use the online calculators or you can use an image guided system depending on what is available. It's not necessary that everyone should use an image guided system. The online calculators, the most commonly and the most widely used calculator for a toric calculator is a Barrett online calculator. So this takes into consideration the posterior corneal curvature, it takes into consideration the ELP, and finally it gives you the toric model of the lens as well as the power of the lens. The advantage of the Barrett online calculator, like I mentioned, it takes into consideration the lens thickness and therefore the ELP is taken care of, and also takes into consideration the posterior corneal astigmatism, which normally ranges from 0.2 to 0.78. Now, if we ignore the PCA, what happens is you could get an overcorrection in a with the rule astigmatism and an undercorrection in the against the rule astigmatism. We also have online calculators from various companies depending on whichever lens you're using, which also are a good option available. Image guided systems are a very good tool if it's accessible to use for the preoperative planning. I have experience with the Varion. You have either the Varion or the Callisto. Again, here you can compare the various keratometries, all the keratometries which you have fed in from the other instruments, as well as the keratometry measured by the varions, and you can either take the two closest matching keratometries, or you can take in the keratometry which is a median or an average of all the you also can have a comparison of the different IOL formulae, and you can change the wound architecture, the size of the wound, the position of the wound, and thereby achieve a better result. Now, you can see in this particular video of a varion planning, we are changing the position of the wound from a 0 to a superior incision, and see the residual astigmatism over here, how it is decreasing. We started off with a 0.18 of a residual cylinder, and if we do the incision, say somewhere about 90 to 95 degrees, we can reduce the astigmatism, the residual astigmatism, to almost 0 with the same model lens or the different model lens. Again, we can do this by changing the wound size. But the most important thing here to understand is one should know what is one's SIA, that is surgically induced astigmatism. The SIA varies depending upon the site of the wound, and also varies depending upon the size of the wound. So we have to calculate our SIAs for different wound incision positions and different wound sizes. So a 2.2 or 2.8, if you're using both of these incisions, again a superior incision will have a different SIA from the temporal incision. Now, the basic requirements is just a sample size of about 30 to 50 cases. You can either do it on a varion. Again, very important that the pre-operative and the post-operative keratometry should be measured on the same instrument, so that there is no error in calculating the SIA. So you can either do it on a varion, or you can do it by sending all this data to Dr. Warren Hill's website, where it automatically calculates your SIA, and this can be used for all your future calculations. Coming to the intraoperative considerations, the toric marking is something which is very important. You can either do a freehand marking using various markers available, making the position sit in a vertical position so that there is no cyclotorsion. Various markers are available, and I'm sure all of us have been using these. There is a slit lamp method of marking, where the slit lamp beam is oriented to the 0-180, and a marking can be made with a pen. It's important to mention here that all markings, whether it is pre-op or intra-op, should be done with a very, very fine and a sharp tip pen, because if there's a smudge, there can be a difference of almost 4 to 5 degrees in the alignment of the lens. The third marking is obviously on the OT table, that is the final lens position marking. We can also have, since everyone has been using smartphones, we can also have various smartphone apps which are available today for getting the 0-180. That is, you have one from Dr. Saurav Patwardhan, you have a toric axis marking called Tor axis, or a Toricam axis which Dr. Graham Barrett has released on the App Store. Image guided systems are another good method, where you get a markerless system, and from this markerless system one can align the lens to the right axis. So what are the three important steps in the toric alignment marking? First is a gross alignment, where you align the lens markings to almost 10 to 15 degrees of the intended position. You then remove the viscoelastic, and finally you do a final alignment and centration of the lens. So this particular video I'd just like to show, the lens has been placed inside. One second. We are now dialing the lens into position. I'll just clean this up in the interest of time. And as you can see, it's always a clockwise rotation which is to be done, especially for the C-loop IOLs. You keep rotating, you keep dialing the lens until you are almost about 15 degrees from the intended position. Having done that, you go behind, get out all the viscoelastic from behind the lens, do an aspiration irrigation, remove the viscoelastic from in front of the lens, and then you would finally align the lens to the final position. Otherwise, what happens is when you already align the lens to the final position and you then start doing a viscoelastic removal, there can be a further rotation of the lens, and then to rotate it anti-clockwise could be a very, very difficult task. Toric IOLs and high myopes, it's very important to understand that patients with a large axial length, especially the ones above 25 millimeters, have a large bag, and there's poor peer-reviewed literature has proved that's pure toric IOL stability. So it's ideal in these cases to consider using a CTR to prevent the toric IOL from rotating after in the post-operative phase. Again, in a small pupil, sometimes it's very difficult to visualize the markings. And in these cases, what can be done is you can nudge the lens a little downward in the opposite direction to see whether the markings are in sync with the final toric axis marking. We have also developed a new instrument called as a duolator. This is the instrument which is a combination of a dialer and a Y hook. So this can be used with the irrigation from one port. You can gently push the pupillary margin, check the alignment, and if it's not in sync, I'll take about a minute or so, you can dial it with the same instrument. You don't have to come back again and use another instrument to dial the lens into position. So what happens if you overshoot the intended axis? It's very important that once you overshoot the intended axis, do not try to rotate this lens in the anti-clockwise direction. You need to spend time. You need to again, as you can see here, we have overshot the final position, and it's important that you re-rotate the lens. You may have to spend time, you may have to do a 180 degrees rotation again, but it is always better to rotate it in the clockwise direction. End of the surgery, very important that you check that all the viscoelastic has been removed, because leaving viscoelastic in the back can cause a post-operative rotation. And the final step after having injected the intracameral antibiotic is depress the lens downwards towards the posterior capsule while you are injecting maybe the saline to form the chamber, or when you are injecting the intracameral antibiotic. The depression of the lens helps in two things. It helps in pushing out all the BSS from behind the lens, and it helps the lens to adhere better to the posterior capsule without any interface. So these two steps are very important in preventing postoperative rotation of the lens. So the take-home message would be: use multiple instrumentation to confirm your measurements in the preoperative planning. Include posterior corneal astigmatism by using an advanced calculator. Optimize your surgically induced astigmatism, and ensure a proper alignment of the IOL to the desired axis. Thank you.
Thank you so much, Dr. Nitin. That was really a very lucid presentation. Can I have a head count? How many of us are using Torics regularly? So I think that's almost half the number of people here. And what's the reason for the others not using? Those of us who are not using it regularly, is it some fear? Is it lack of access to certain instrumentation? So, so now you've had a very clear, roadmap from Dr. Nitin. Okay. So it's good to try to analyze why did you have that refractive surprise. We'll be going into that much later. But I would just say that there's nothing to fear, because actually the best way to start your premium IOL practice is to start with Torics. They give you very good results, and the worst comes to worst is that you'll have a little bit of undercorrection. As you know that every degree causes, I mean, if you don't get your axis right by say 30 degrees, then you could lose the toricity. But otherwise you're on very safe ground. So Dr. Nitin has given you a very clear way. I think you should start with Torics. Do not fear anything more than 1.5 initially, diopters of astigmatism. Go straight for a Toric. You'll have many more happy patients coming back to you.
And a better way of starting would be to start with a higher astigmatism. You start and see whether it is with the rule or against it. You start with the rule, then you have a better satisfied patient.
Yeah, Parul, you want to say something? Yeah, but Parul, I would just beg to differ from you. Even if you don't have access to an optical biometer, if you do it even on your manual keratometry, it's calibrated and you do it properly, and you do it on your auto ref also. If you have two readings in which it's coinciding. You can be fairly sure of getting accurate readings. And as Dr. Parul already said, stabilizing your ocular surface is extremely important. Dry eye can be a big game changer in toric lenses. So it's very important to look whether your patients have dry eye.
One more thing is that you should analyze, is it because the axis that you planned and the axis that you have got, has there been some of the lenses rotate more? So, just try to analyze.
Hearing all this, I think the problem is my patient was myopic, the big bag was there.
So I'm sure you'll,
Something like that because the bag was quite big. So
right.
maybe I didn't need the posterior surface so wide or bag was big, something like that.
I'm sure you'll do better now when you go back.
And initially, when you have that nature, you're scared of even attending to the patient longer when you've done a premium IOL. So I think half of the people are scared
I
of
didn't
even
do
dilate.
medium, I just take normal first. Let me try.
I think toric IOLs are very safe. You